Hey all, so today we are going to discuss about removable partial denture. So why do we need a removable partial denture? Basically, when we want to preserve the teeth present in our oral cavity as such and want to replace the absent ones, right? Then we provide the removable partial denture. So it has a benefit of that the individual can remove it and place it at his will, at his or her will. So it is basically defined as a prosthesis that replaces some teeth in a partially dented arch. It can be removed from the mouth and replaced at will. So it is also known as partially removable dental prosthesis. This definition should be learned as such. This is a standard definition of removable partial denture. So RPD is basically of two types. First one is acrylic partial denture. So as you can see in this picture, that is an acrylic partial denture, and you can see wrought wire clasp over here. These acrylic partial dentures are known as flippers. These are known as gum flippers basically. And the disadvantage of these gum flippers or acrylic partial denture is it causes gingival recession with long-term use. That's why it is also known as gum strippers, because they cause gingival recession. So the second type is cast partial dentures, which are fabricated by lost wax technique, lost wax casting method. Which is further of two types basically. Clasp retained cast partial dentures, here you can see a clasp, and attachment retained cast partial dentures. Now the temporary RPD, they are used where tissue changes are about to occur. They are of three types. First one is the interim dentures. So the interim dentures are basically given for short time for the reasons of aesthetics, stability and function such as mastication, or basically for the convenience until a definitive form of treatment can be rendered. Now the second one is the transitional RPD or transitional denture. This is basically an interim prosthesis to which artificial teeth will be added. So it aids the patient in making transition to a complete denture, right? And the third one is the treatment denture. They are basically used for treating or conditioning the soft tissues, which are basically abused by ill-fitting prosthesis. Now the indications of the RPD, basically you know very well distal extension situations, long edentulous spaces, or we need aesthetic purpose, immediate replacement, obturation of intraoral defects such as cleft lip and palate, and abutment with questionable prognosis, excessive residual ridge resorption. But one of the feature is very important, or one of the indication is very important, that is our cross arch stabilization. Very important. Why? Because the main advantage of RPD over the FPD in replacing bilateral lost teeth is cross arch stabilization. Whenever we want to replace bilaterally lost teeth, we need a cross arch stabilization. In those situations or in those conditions, RPD is far better than the FPD, right? And rest you know, like poor prognosis for complete denture, alteration of vertical dimensions, etc. And the contraindications of the RPD is basically the patients who lack the dexterity to insert prosthesis, patients who do not care to maintain oral hygiene, or the epileptic patients where there is a danger of swallowing the denture during an attack. Now the components of removable partial denture, these are connector, retainers and denture base and replacement teeth. Connectors are further of two types, major and minor connector. Same, retainers are further of two types, direct and indirect. And the direct retainer is having three components, that is rest, retentive arm and the reciprocal arm. So this is basic design of RPD, which you can appreciate in this picture, right? So this is the major connector, the A. These are the minor connectors, this portion. Now this is the indirect retainer, and this hole is direct retainer, which is having three parts, that is the retentive arm, the rest and the reciprocal arm, right? Now for classifying edentulous areas, we are having a Kennedy's classification, basically having four classes. So the class one is bilateral edentulous area located posterior to the remaining natural teeth. And in class 2, you can see there is unilateral edentulous area located posterior to the remaining natural teeth. Now the class 3. Class 3 is unilateral edentulous area with natural teeth both anterior and posterior to it. And last one is the class 4, which is a single bilateral edentulous area located anterior to the remaining natural teeth, which is crossing the midline basically. Now there are certain rules for classifying edentulous areas. These are known as APPLEGATES rules for Kennedy's classification. So the rule 1 is classification should follow rather than precede any extraction of the teeth that might alter the original classification. So first we need to extract the tooth, then we are supposed to classify the edentulous area. Rule number 2, if the third molar is missing and we are not supposed to replace it, so we are not going to consider it in the classification. Now what if the third molar is present and we are going to take support from this molar? Then this third molar is to be considered in the classification. Now the APPLEGATES rule number 4, if a second molar is missing and is not to be replaced, we are not going to replace it, so we are not going to consider it in a classification. Rule number 5 is the most important rule, that is the most posterior edentulous areas, that is the posterior most areas will determine the classification. Now the rule number 6, basically this is here in this picture, you can see this is the most posterior edentulous area. So this will determine the classification. So this is basically class 3, right? So, and what about this region? This space other than the edentulous area which is determining the classification is known as the modification spaces. So this is basically class 3 modification 1, right? The rule number 7 says that the extent of modification is not considered, only the number of additional edentulous areas are considered. So this is the most posterior region that will determine the edentulous area, that is this is basically the class 2. So and this is class 2 modification 1, right? Here also this is the most posterior region determining the classification, therefore this is also class 2, and the edentulous space is basically 1 only, that's why it is also known as class 2 modification 1, right? Now the rule number 8, so there can be no modification area in class 4 because the class 4 is basically the anterior edentulous area, but we know that the posterior most edentulous area determines the classification. So the posterior most region, posterior most edentulous area is this one. So this is basically class 3 that will determine the Kennedy's classification, and this is only single one edentulous space present, that's why this is class 3 modification 1. So therefore we cannot have any modification area in class 4. Now the APPLEGATE Kennedy classification. So APPLEGATE attempted to basically expand the above classification. So basically considering the condition of the abutments. So the class 5 in which an edentulous area is present, which is bounded anteriorly and posteriorly by natural teeth, but in which anterior teeth is not suitable for support. That is considered as class 5, where anterior teeth is unable to provide support for the RPD. And the class 6 is basically an edentulous area in which the teeth adjacent to the space, like these, that is the premolar and the molar present adjacent to the edentulous space, are capable of total support required for the prosthesis. Thanks for watching.